The truth about amlodipine and losartan, the secrets doctors won't tell seniors. Hello, my friends. I'm Dr. Rachel Storms. And today I want to give you something most people never get in a short doctor's appointment: the open secret about amlodipine and losartan. These are the two medications that an enormous proportion of adults over 60 take every single day, often together, often for years, often with only a fraction of the information they need to take them safely and effectively. If you are over 60 and you take either of these medications or both, this may be the most important video you watch this year. Your physician prescribed these medications to protect your life from heart attack and stroke, and they do exactly that. They are lifesavers. But there is fine print about how they interact with an aging body that almost never gets discussed in a 15-minute appointment, and that fine print is what we are covering today. Before we go any further, I want to be absolutely clear about something. I am not telling you to stop your medication. I am not telling you that your medication is dangerous in a sudden or dramatic way. What I am telling you is that there is specific information about how these medications behave in older adults that allows you to be a more informed participant in your own care. Without this information, you cannot ask the right questions or notice the right warning signs. The goal of this video is not to undermine your trust in your physician. The goal is to give you the exact questions to ask your physician at your next appointment, so that the conversation moves into a genuinely individualized plan for your body. Stay with me through the entire video, because at the end, I am going to describe a specific symptom that the vast majority of older adults attribute to normal aging. But that is in fact a direct warning sign from these medications. Recognizing it for what it is may change what happens at your next appointment. Let me start with amlodipine, the silent swelling problem that I see constantly, and that is one of the most poorly managed side effects in cardiovascular medicine. Amlodipine is a dihydropyridine calcium channel blocker. It works by relaxing the smooth muscle in artery walls, causing the vessels to widen and the blood pressure to fall. The mechanism is excellent, and the medication is highly effective, but it has a quirk that is responsible for the ankle and lower leg swelling that affects many patients. The quirk is that amlodipine relaxes the small arteries in the periphery more than it relaxes the small veins. This creates a pressure mismatch in the capillaries. Fluid leaks out of the bloodstream into the surrounding tissues. The result is the visible swelling in your ankles, particularly by late afternoon and evening. Here is what most patients are not told about this swelling, and this is the open secret I want to expose. It is not heart failure. It is not kidney failure. It is not a sign that you are retaining dangerous amounts of fluid throughout your body. It is a local mechanical issue caused by the medication's specific vasodilatory pattern. The fluid that appears in your ankles is not new fluid added to your body. It is fluid that has been redistributed from the bloodstream into the local tissue spaces. Why does this distinction matter? Because the most common medical response to ankle swelling on amlodipine is to add a diuretic, a water pill like furosemide. Instead of addressing the side effect directly, a second medication is added to manage it. This is the prescribing cascade I want you to know about. The second medication has its own side effects, sometimes more serious than the original problem, including dehydration, electrolyte abnormalities, and increased fall risk. The patient now has more medications, more side effects, and the original swelling is often only partially relieved because the diuretic does not address the underlying mechanism. The correct response to amlodipine-induced edema is not to add a diuretic. The correct responses include reducing the dose or switching to a different subtype. Adding an ACE inhibitor or ARB counteracts the asymmetric vasodilation through a complementary mechanism. This is a conversation worth revisiting with your physician. There is also a practical implication. The fluid that accumulates in your legs during the day does not stay there when you lie down at night. It redistributes back into central circulation, reaches the kidneys, and contributes to nighttime urination. The fatigue from that sleep disruption is often attributed to aging. Now let me turn to losartan, where the open secret involves potassium and the kidneys. Losartan is an angiotensin receptor blocker. It works by blocking the hormone angiotensin II from constricting blood vessels and telling the kidneys to retain sodium, but it also reduces potassium excretion. The kidneys hold on to more potassium than they would without the medication. For most patients, this stays within a safe range, but for older adults, things change. The first factor is salt substitutes. Salt substitutes marketed as heart-healthy alternatives are typically made of potassium chloride. A teaspoon contains 2,500 milligrams of potassium. Patients who switch to a salt substitute are inadvertently loading themselves with potassium on top of a medication that is already telling their kidneys to retain it. The second factor is age-related decline in kidney function. After 60, kidney filtration capacity declines progressively, even in the absence of any specific disease. Reduced filtration means reduced ability to excrete potassium. The medication and the age-related change compound each other. This is a critical factor for seniors. The third factor is medications that further reduce potassium excretion, including potassium-sparing diuretics and even some antibiotics like Bactrim. The combination of these factors can produce serum potassium levels high enough to disrupt cardiac electrical conduction. This state is called hyperkalemia. Hyperkalemia has subtle early symptoms that are easy to dismiss: muscle weakness, fatigue, palpitations, or mild tingling in the fingers or around the lips. Severe hyperkalemia produces arrhythmias that can be life-threatening. Routine monitoring may not catch the rise until it's well above the safe range. The kidney implications of losartan extend beyond potassium. Losartan reduces filtration pressure inside the kidney as part of its protective mechanism. But in an aging kidney with reduced reserve, this can produce acute kidney injury when combined with stressors like dehydration, infection, or NSAID use. The patient who develops a stomach virus, continues their losartan without adjusting fluids, and ends up in the emergency department is a scenario I have seen many times. Now let me turn to the synergy of these two medications when prescribed together. This combination is genuinely effective at controlling blood pressure. It attacks blood pressure from two angles. Amlodipine relaxes the muscle, and losartan blocks the hormonal signal. The result is better control with lower doses. But the combination also has cumulative effects. Both produce some degree of orthostatic blood pressure change, a drop in pressure when you stand up. The dizziness when standing, the lightheadedness in the morning. These are not features of aging. They are direct pharmacological effects with real fall risks. Let me tell you about Margaret. She is 74. Her daughter noticed she had become increasingly fatigued, foggy, and avoided activities. Her blood pressure was beautifully controlled on high doses, but when I checked her standing blood pressure, it dropped 28 points systolic. We adjusted her regimen, reduced the amlodipine, and shifted the losartan to evening. Within 6 weeks, Margaret felt like herself again, walking and thinking clearly. Now for the symptom I promised. It's the brain fog, specifically in the first few seconds to minutes after standing up. It's orthostatic hypotension. Every episode of orthostatic hypotension is a moment of underperfusion of the brain. Repeated underperfusion contributes to cumulative neurological damage. This contributes to the cognitive decline that older adults so often attribute to aging itself when it is partially a consequence of cardiovascular medication. The home test is simple. Sit for 5 minutes, take your pressure. Stand up, wait 1 minute, take it again, then again at 3 minutes. Compare the numbers. A drop in systolic pressure of more than 20 or a drop in diastolic of more than 10 qualifies as orthostatic hypotension. Bring those to your doctor. First, is my target appropriate given my age? Second, am I being monitored for potassium? Third, can we check my orthostatic pressure today? And fourth, are any medications in my regimen only there to manage side effects of others? These questions signal that you are an engaged participant. If this helped you, share it with a friend who takes these medications. Post it on Facebook or WhatsApp. This information is what every patient deserves. Sending this is an act of care. Watch my next video on morning habits for blood pressure next. I'll see you there.